Uh, so without further ado, we'll start with the class. I've introduced myself. I'm Mr. DME, and I will be taking in the first 2 weeks of this course, where I'll be introducing you to the basis for diseases. So the idea behind this introduction is to help you see the cellular view of how diseases start. So we're going to talk about how the gross morphology of cells. We're going to talk about how cells try to adapt to stresses. We're also going to look at how cells in the long run as well, how they adapt, and look at the subcellular structures that help the cells adapt to those stressors. And then, of course, um, adaptation is not perfectly elastic. So it means that at some point, the cell will become injured. So it will become irreversibly injured at that, and it will die. So what are those processes that happen to make cells, pass through such changes, right? Right from your undergraduate, from your first year in biology and also in physiology, you've been told that cells are active participants in the environment, and you've been shown how cells are likely to also maintain a balance between their internal environment and their external environment in a process called homeostasis, right? Um, all of that is part of the processes for disease formation, right? So cells are active participants in the environment. They're constantly adjusting their structure and function to accommodate changing demands and extracellular stresses. Cells tend to maintain their intracellular milieu within a fairly narrow range of physiological parameters. I mean, that's still what you call homeostasis, right? Now, as cells encounter physiologic stresses or pathologic stimuli, they can undergo adaptation, achieving a new steady state while preserving viability and function. Now, cells do that so that their function continues, even though their cell state may change. Okay. Excuse me. Now, the principal adaptive responses that cells undertake are basically hypertrophy, hyperplasia, atrophy, and metaplasia, right? And if this adaptive capacity is exceeded, like I mentioned, it's not a perfectly elastic um, uh, feature, right? So if this adaptive capacity is exceeded, or if the external stress is inherently harmful, for example, exposure to toxins or corrosive chemicals, right, the cell will become injured, right, and then the cell will die. Once there's irreversible injury, the cell dies. Cell death is also one of the most crucial events in the evolution of diseases in any tissue or organ, because it results from diverse causes. Cell death can come from ischemia, infection, toxin, or even immune reactions. Cell death is also normal, and it's an essential process in growth, in embryogenesis, in the development of organs, also in the maintenance of homeostasis, right? So in this part of the session, we're going to be looking at the relationships between what is normal, what is adapted, reversible and irreversible injury, and we're going to be talking some more. One of the examples that I think perfectly illustrates that relationship is actually how the muscles of the heart, the myocardium, how they respond to stress. In fact, it's one of the most versatile cells that demonstrates to us what happens in the long run in terms of if a cell becomes, if a cell adapts to to stress, and then if that stress is not removed, when it gets injured, you can visually see it, you can see the effect on the heart, and then you can also see when the cells become irreversibly injured, and then you can see when it progresses from that irreversible injury to cell death, right? The myocardium uh, is subjected to persistent increased load, and when that load, the load is subjected to is the force, is that contractile force that it has to go through to pump blood or fill with blood. And when it does that, uh it bears some load, so it goes through different shapes to pass on the force of contraction to either open up the heart chambers or to close it in order to force blood out. Now, when that force is increased, for example, during hypertension, right, the shapes of the myocardium is changed, and then the cells hypertrophy, which you can see with my cursor, pointing to. This is a case of hypertrophy. The normal myocyte increases in size. Now, what happens here is that the 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 cell organelles, that's the those tiny organs within the cell themselves, they increase in number. It increases its protein filaments. It increases its elastin within the cell wall in order to adapt to the increased force it needs to push blood out. And when it does that, by increasing its intracellular proteins, the cell becomes larger, right? Which you can see from this gross cut on the heart's myocardium. Now, when this becomes, sustained and unchanging, the myocytes, that's the cells of the muscles of the heart, can become reversibly injured. And now, when they become reversibly injured, there are certain states that you will find within the cell. For example, you find fat agglutination within the cell itself, and then you find some other changes. For example, in the cell wall, you find significant changes, but it has still not become irreversibly injured at this point. But at the point where you find breakages in the cell wall, and you find that, in fact, anything that causes an irreversible injury would affect the homeostasis within the cell. So once you find that homeostasis can no longer go on within the cell, that cell has become irreversibly injured and will progress to cell death. Now, these areas that are colored yellow are areas where they are called areas of infarct. So those are areas where cells have died and can no longer function at that point. So once a cell becomes irreversibly injured, they lose function, okay, and they die. I hope we understand. Like I said, if you have any questions at any point, feel free to raise your hand. I'll take your question, and then we'll be able to go. But I've muted everyone this time, so we can have it. Okay, so if you have any questions, please feel free to raise your hand. We'll take that question. Thank you. Okay, so this is a bit to demonstrate to us what it looks like when there's the whole range from cells adapting to stress and then on to where there's injury and cell death. Adaptations are reversible changes in the number, it can be in the metabolic activity, and can be in function of cells. All of this in response to changes in the environment. It can be physiological, it can also be pathological. Physiological adaptations usually represent responses of the cells to normal stimulation by hormones or endogenous chemical mediators. For example, endogenous hormone-induced enlargement of the breast and uterus during pregnancy. There can also be pathologic response, and these are stressors that allow cells to modulate their structure and function and escape injury. Okay, such adaptations can take several distinct forms, and it's important to note these. I've mentioned them before. There's hypertrophy, there's hyperplasia, atrophy, and metaplasia. Now, hypertrophy is an increase in the size of cells, resulting in increase in the size of the organ. Okay, so in hypertrophy, the size of the cells, please note this because these are subtle differences that you'll find between the ways cells adapt. Okay, hypertrophy is increase in the size of the cell. Sometimes you may confuse that with hyperplasia. Hyperplasia is increase in the number of the cells, while hypertrophy is increase in the size of the individual cells, right? That's what happens, for example, in the myocytes, in the cells of the myocardium, right? Hyperplasia, on the other hand, refers to increase in the number of cells. So that hyperplasia commonly occurs in cells that divide frequently. But what you have happening in hypertrophy is that cells that cannot divide rapidly grow in size to accommodate the stress they are under. Okay. So stated in another way, in pure hypertrophy, there are no new cells, okay, just bigger cells, enlarged by an increased amount of structural proteins and organelles, okay? So it increases structural protein and increases the internal organelles, okay? And when it does that, the cell size becomes bigger, okay? Hyperplasia is an adaptive response in cells capable of replication, whereas hypertrophy, which we're currently discussing, occurs when cells are incapable of dividing. Hypertrophy can be physiologic, it can also be pathologic, and is caused either by increased functional demand or by specific hormonal stimulation. Hypertrophy and hyperplasia can also occur together. That's possible. Okay. An example is in the enlarged uterus, in the enlarged gravid uterus. That's when the woman becomes pregnant. But the cells in the uterus, they divide more, and then they also increase in size to accommodate the growing fetus. Okay, in that way, the uterus is able to enlarge very rapidly within a short period of time to accommodate the growth of the fetus. But of course, that's a physiologic process, not a pathologic process. In contrast, you can have the striated muscle cells in both skeletal muscle and the heart. They undergo pure hypertrophy because they cannot replicate as fast as, in response to demand like the uterus. So what you have is, just growth in the internal organelle and then the structural proteins to achieve a larger structure. The mechanism driving cardiac hypertrophy, like you saw here, right, where the cells become larger, right, involve at least two types of signals, mechanical and trophic, right? And, mechanical triggers are stretch triggers. So, for example, when the heart has to expand beyond what it normally does, for example, in people who have hypertension associated with fast heartbeats, Okay, that faster, beating of the heart forces the heart chambers to contract for longer. Okay, so that stretches the myocardium of the heart beyond what it normally experiences. That is called a mechanical trigger. So it's a stretching and collapsing on itself. It triggers it to expand, to grow more structural proteins, and also to increase the internal organelles, right? And then it can also go through things called trophic triggers. Trophic triggers include activation of the alpha adrenergic receptors, and activation of alpha adrenergic receptors can also happen when the body, for example, is trying to cope with increased peripheral resistance. Of course, you know that blood pressure is if you represent blood pressure mathematically, it's stroke volume times cardiac output, right? And the cardiac output is a function of the peripheral pressure, peripheral resistance, right? So once you increase the cardiac output, it means you increase the peripheral pressure as well, right? When you increase peripheral pressure, it activates the heart muscle as well, and then the heart muscle that's a trophic signal to the heart muscle as well to increase in size, because it sends biochemical information to the heart muscles telling it that there's increased load, so it has to increase its capacity to function appropriately, that's to distribute blood appropriately around the body. Okay, so those are the two triggers we have, mechanical triggers and trophic triggers, right, that tell the heart muscle to increase in size. Now, these stimuli turn on signal transduction pathways that lead to the induction of a number of genes, which in turn stimulate synthesis of numerous cellular proteins, including growth factors and structural proteins. Now, the result is the synthesis of more proteins and myofilaments per cell, which achieves improved performance, and thus you get a balance between the demand and the cell's functional capacity. Along the line, there may also be a switch of contractile proteins from the adult to fetal or neonatal forms, and that happens when the stressor is not removed in the long run. Okay, the heart muscles do the cells of the muscles of the heart do that so that it can rapidly change. So it switches from the adult rigid contractile proteins to the fetal or the neonatal form, which is much more extensible, right? But is also subject to rapid change as well. Okay. For example, during muscle hypertrophy, the alpha myosin heavy chain, I'm sure you've already seen this. It's one of the popular examples used to demonstrate the structure of cells in physiology, right? Especially when you're doing macrophysiology. It's part of what is usually taught to demonstrate, structures within the cell and how each one, is modified until an adult cell is achieved. Okay, so during muscle hypertrophy, the alpha myosin heavy chain is replaced by the beta form of the myosin heavy chain, which has a slower, more energetically economical contraction. Whatever the exact mechanism of hypertrophy, a limit is reached. That's the main point. A limit is reached beyond which enlargement of the muscle mass can no longer compensate for increased burden. So, for example, someone who has hypertension, right? You all know that there's a point at which the pressure increases on the heart, and the heart can no longer cope with that pressure, and then we say that there is heart failure, right? So there's a limit that is reached beyond which the enlargement of muscle mass can no longer compensate for the increased burden. And when this happens on the heart, several degenerative changes occur in the myocardial fibers, okay, of which the most important parts are fragmentation and loss of, internal elements. Now, these variables continue like that, okay, causing, poorer changes until there is heart failure, okay. So this is important to demonstrate that all of the changes we see in Ross disease, for example, in hypertension, all have cellular impact. So they have things that are going on cellularly, and then they also have subcellular changes that are going on. For example, like we said, there's myofilament changes in the myofilament, there are changes in structural protein as well. Now let's quickly talk about okay, talked about this. Okay, so let's quickly talk about hyperplasia, right? Hyperplasia takes place if the cell population is capable of reproduction. Of course, a very popular example of a cell that that can replicate very fast is the liver cells, right? The liver is one of the most versatile cells in the body, right? That's taken away. I mean, that doesn't take away from the cells in the lumen of the stomach and within the lumen in the intestine, right? But the liver cells, for example, if you resect the liver cell, it can regrow itself within 48 to 72 hours. It can regain its old mass, so it's practically the most viable in the entire human body, right? I mean, if you talk about function in terms of speed of recovery and how fast it achieves its function back, the liver is one of the most efficient in doing that. Hyperplasia can also be physiological. It can also be pathological. On the physiological, we have two types: hormonal hyperplasia, which is exemplified by proliferation of glandular epithelium of the female breast at puberty and during pregnancy. Secondly, there's also compensatory hyperplasia. That's hyperplasia that occurs when a portion of the tissue is removed or diseased. For example, when a liver is partially resected, mitotic activity in the remaining cells begin as early as 12 hours later, right? Eventually restoring to the liver to its normal weight. Okay, the stimuli for hyperplasia in this setting are polypeptide growth factors. So the body mobilizes polypeptide growth factors to the site, and that results into a cascade that eventually increases cell replication, makes available the appropriate nutrients and micronutrients that the cell requires to multiply really fast and regain its initial weight. Okay. After restoration of the liver mass, cell proliferation is also biochemically turned off, and so the liver, just continues to function. The polypeptide growth factors and micronutrients are mobilized away from the liver at that point, and then the liver continues its function. Now, in terms of pathological hyperplasia, these are caused by excessive hormonal or growth factor stimulation. An example is after a normal menstrual period, there's a burst of uterine epithelial proliferation that is normally tightly regulated by stimulation through pituitary hormones and ovarian estrogen, and by inhibition through progesterone. However, if the balance between estrogen and progesterone is disturbed, you can have endometrial hyperplasia, right, which is a common cause of abnormal menstrual bleeding. Hyperplasia is also an important response of connective tissue cells in wound healing, in which you have the proliferating fibroblasts and blood vessels. They aid in the repair of injury. In that process, you have growth factors are produced by the white blood cells, that's the leukocytes, that are responding to the injury, and by cells in the extracellular matrix. That stimulation by the growth factor also is also common when you have viral infections. For example, when there is a papilloma virus infection, that's what results into the inflammatory process that results into warts. I'm sure some of you have seen skin warts before, right? So that's what results into the formation of skin warts. That inflammatory process results into that, right? How have I skipped 2 slides? Okay, so that inflammatory process is when the virus is attacking the epithelial cells, leads to the formation of skin warts and sometimes mucosal lesions composed of hyperplastic epithelium. The danger here is that some of these can become hyperplastic in future, leading to cancers. Okay, so that's why it's important to as a disease process as well. Okay, let's go on to atrophy, which is a very interesting adaptation, right? Atrophy, this is shrinkage in the size of the cell. And this shrinkage occurs because the cell loses its component, cell substance. It loses proteins, it loses some of its water, loses some of its organelles as well, right? It doesn't mean that that cell is dead, right? In fact, okay, I'm not sure. Okay, I did not include a picture. I would have loved to show you a picture just to demonstrate to you what atrophy may look like. Probably in the next class, I'll remember to bring up a picture. But then if you compare the brain of a young person, for example, anybody in your class, for example, compare your brain to the brain of someone with atherosclerotic disease, right? There are significant differences. For example, the brain mass reduces in people with atherosclerotic disease because blood supply is not sufficient, no longer sufficient to that organ. So you find that some of the brain cells shrink in order to ensure there's adequate supply to others, right? And then that part that shrinks, it's not dead, right? But it's not functioning at that point. So the cells do that too in times of starvation, in times of I think that's an important example. In times of starvation, right? You see people shrink in their size, and that's because there's inefficient supply of nutrients, leading to reduction in the cell sizes. Some of the cells that are not essential, well, let's say essential at that point, to maintain function, will lose their cell component. They go into a resting state, and then other cells that are important to continue life continue function with whatever nutrient is available, or whatever they end up eating from those other nutrients that have gone into that have gone into resting state. Okay, so those cells are not dead. And the causes of atrophy can include decreased workload. For example, if you also immobilize the limb, maybe a broken limb from a fracture, that can lead to the limb becoming smaller. If any of you have had a broken limb before that had to be in a cast for maybe a month or more, right? You would usually notice, especially if you're someone who's athletic, that that line will look or appear smaller than the other line. Than, for example, if it's the hand, the muscles will seem to have shrunk compared to the second hand. If it's the leg, the same thing. Okay, that's atrophy. It can also happen when there's the loss of innervation to a line. For example, when there's in adulthood, if someone loses innervation to their hand or to a particular limb, you'll notice that that limb becomes smaller. Sometimes if it results from an accident, the shrinking is very noticeable anyway. I think that's what I want to point out, that usually once that happens, the shrinking is, you can see it once there's a loss of innervation to that. Or maybe someone who, for example, has a spinal cord injury, over time, you see that possibly, let's say they lose innervation to their legs, right? Over time, you'll find out that the legs begin to shrink or lose function. Okay. Now, although some of these stimuli are physiologic, for example, the loss of hormone stimulation in menopause, some are pathologic, like denervation, right? Where I said that someone loses feeling in a particular part of the body, right? The fundamental cellular changes in both of these cases are identical, either physiological or pathological. The changes are identical. They represent a retreat by the cell to a smaller size at which survival is still possible. A new equilibrium is achieved between cell size and diminished blood supply, nutrition, or trophic stimulation. Atrophy results from decreased protein synthesis and increased protein degradation in cells. The protein synthesis decreases because of reduced metabolic activity. Very important. Like I said, what is happening is that there isn't enough nutrition available, or there are trophic signals that tell that part of the body that it is no longer required to produce or function, right? When there's loss of innervation, right? Now, this protein synthesis decreases because of reduced metabolic activity. The degradation of cellular proteins occurs mainly through the ubiquitin proteasome pathway. You can see that here. And under mechanism, I've listed decreased protein synthesis and increased protein degradation. Now, the main process by which protein degradation happens, like I mentioned, is the ubiquitin proteasome pathway. And this is a very common reaction in a condition called cancer cachexia. Cancer cachexia is a life-threatening condition, and sometimes it's manageable, but most patients who go into cancer cachexia end up dying. It's an inflammatory process, and it's important that in managing patients with cancer, you constantly watch out to ensure you do not trigger cancer cachexia in the patient. In many situations, atrophy is also accompanied by increased autophagy. You came across that term autophagy in your either in biochemistry or in physiology, right? Which resulting increases in the number of autophagic vehicles. Autophagy is self-eating. That's a process by which the cells eat up its own components to survive, right? So when cells are starved of nutrients, the cells eat its own components in an attempt to find nutrients to survive. Okay, so that's a main these are the main processes by which the cells become smaller and go into resting phase. I hope we're all following. Like I said, if you have a question, please raise your hand. We'll take it, and then I'm going to end with when we describe metaplasia. But I'll also, like I mentioned, I'll make the recording and I'll make the notes available to you by the end of the day. I also need to find out, do you all have access to the LMS at this time? If you want to respond, you can just raise your hand. Do we all have access to the LMS at this time? Or you can post in the chat as well. Oh, you do not have access to the LMS. Okay, but some people have. Okay, so those who don't have access to the LMS, please get to the sub-dean. You need to reach out to the sub-dean because your lectures are going to be posted on the LMS, and then you're going to also do some of your in-courses on the LMS. So that needs to be resolved very quickly, okay? So please reach out to the sub-dean so that that can be sorted out quickly. Okay, before the end of this week, you need to sort that out because all of the study materials you need, some of the textbooks will also be placed on the LMS for your use. So please sort that out before the end of this week. You can go to the sub-dean's office anytime between, I think, 9 a.m. to 4 p.m., right, to get that resolved. Please do that within this week. Thank you. So let's quickly describe metaplasia. Metaplasia is a reversible change in which one adult cell type, epithelial or mesenchymal, is replaced by another adult cell type. In this type of cellular adaptation, cells sensitive to a particular stress are replaced by other cell types that are better able to withstand the adverse environmental influence that we're trying to escape. Metaplasia is thought to arise by generic reprogramming of stem cells rather than differentiation of already differentiated cells, okay? Which means that those adult cell types are replaced by, cells that are differentiating to replace it with a different cell type, not that the adult cell types are just, not that the adult cell types themselves, change into other forms. So it means that those adult cell types, once they're injured, they are replaced by more sturdy, cell types when from the, what's it called? From the stem cells, okay? Epithelial metaplasia is exemplified by the squamous change that occurs in the respiratory epithelium in habitual cigarette smokers. Okay, people who have smoked for a while, if you take a sample of their respiratory epithelium, right, you find that there are changes. It will usually have changed from the normal columnar epithelium change to squamous epithelium that is more amenable to the toxins from cigarette smoke. So the normal ciliated columnar epithelial cells of the trachea and bronchi are focally or widely replaced by stratified squamous epithelial cells. Now, pathologically, this is what results into smokers having to clear their throats frequently, okay? Because what the cilia would have done in terms of sweeping, you hear that, right? So what the ciliated columnar cells should have done in terms of moving the phlegm down the throat and out of the airway, right, is not normally done. So the phlegm accumulates and becomes thicker, right, in the smoker's throat, and then they have to clear their throat often. You hear Okay, that happens often to smokers because of the loss of the columnar, ciliated columnar cells that are replaced by the squamous cells. Okay, vitamin A deficiency may also induce squamous metaplasia in respiratory epithelium if you have vitamin A deficiency. The rugged stratified squamous epithelium may be able to survive under circumstances that the more fragile specialized epithelium will not tolerate. Okay, and even although the metaplastic squamous epithelium has survival advantages, important protective mechanisms are lost. For example, the mucus secretion and ciliary clearance of particulate matter is lost, like I mentioned, and that results into the constant need to clear the throat. Okay, epithelial metaplasia is therefore a double-edged sword. It helps you cope, and then it also hurts you in the long run. Okay, in fact, in a common form of lung cancer, okay, the squamous metaplasia of respiratory epithelium often coexists with cancers, composed of malignant squamous cells. So it is often thought that that change is the starting point of the metaplastic transformation, within lung cancer patients. This is, that direction of change is not all that always happens. For example, in people who have chronic gastric reflux, the direction of change is different. So, for example, people with chronic gastric reflux, their normal stratified squamous epithelium of the lower esophagus that is exposed to acid, regurgitation will undergo metaplastic transformation to gastric or intestinal type columnar cells. Okay, so that's a very important distinction in gastric in chronic chronic gastric reflux. The change is from the stratified squamous cell to the columnar gastric epithelium, right? Metaplasia may also occur in mesenchymal cells, but less clearly as an adaptive response. For example, the bone is occasionally formed in soft tissues. Sometimes when there's injury, you may find bone formation within the soft tissue, which is an abnormal change. Okay, now just in summary, what have we learned this morning? We've talked about cellular changes. No, sorry. Okay, so I'm seeing your charts now. No, it does not mean that all chronic smokers will develop lung cancer, but it just means that they have increased risk over other people to develop lung cancer. Okay. Yes, vitamin A deficiency can also cause the metaplastic transformation of the ciliated columnar cells in the respiratory tract, cause it to change to the stratified squamous epithelium, okay, which is also a risk factor for developing metaplastic or other metaplastic transformations, to form lung cancer. So vitamin A deficiency is a risk factor as well. Okay, so like I said, just to round up, cellular adaptations to stress include hypertrophy, an increased cell and which is increased cell and organ size, often in response to increased workload. Right? Adegbite, put off your camera. We are not interested in seeing you. okay, which is increased cell and organ size, often in response to increased workload. That's hypertrophy. Is induced by mechanical stress and by growth factors, and occurs in tissues incapable of cell division. Hyperplasia, on the other hand, is increased cell numbers in response to hormones and other growth factors, and it occurs in tissue whose cells are able to divide. And we talked about different types. We talked about the physiological. We said there are two types of its physiological adaptation. We also talked about pathological adaptation as well. We talked about atrophy. We talked about that decreased cell size. We talked about um, uh, decreased cell and organ size as a result of decreased nutrient supply or disuse. Okay. Associated with decreased synthesis and increased proteolytic breakdown of cellular organelles. And metaplasia is change in phenotype of differentiated cells. And this is often a response to chronic irritation that makes cells better able to withstand stress. Okay. With that, if you have any questions, you can raise your hand. And I have a few questions that you can try out when you get the notes. But for now, so if you have any questions, you can ask. You can raise your hand. I'll unmute you, and then you ask your questions quickly. Any questions as we round up this class? Questions from this class or questions from or about the structure of the course itself? Okay, there doesn't seem to be anyone asking a question, so I'm going to let you off at this point and say have a good day and bye.